Hello, and welcome to the MSGERC Grand Rounds webinar series, episode 7, Cutaneous Manifestations of Fungal Infections. Next. I'm Boni Elewski. I'm a professor and chair of the Department of Dermatology at the University of Alabama at Birmingham, in Birmingham, Alabama. And my colleague.
Hi, everyone. I'm G.R. Thompson. I'm a professor of medicine at UC Davis here in Sacramento, California.
Next. So this educational initiative was funded in part by a cooperative agreement with the Centers for Disease Control and Prevention to the University of Alabama at Birmingham. The University of Alabama at Birmingham is collaborating with the Mycoses Study Group Education and Research Consortium and Terra Nova Medica on this initiative. The Centers for Disease Control and Prevention is an agency within the Department of Health and Human Services, HHS. The contents of this resource center do not necessarily represent the policy of CDC or HHS and should not be considered an endorsement by the federal government. Also, if you have a question, you can save it to the very end when we will have time to take questions, and send your questions in the chat box. So today we're going to look at three things. First, we're going to review superficial fungal infections and new developments. Then we're going to move on to cutaneous manifestations of invasive fungal infections. And then we're going to review implantation mycoses. Next. So we're going to begin with superficial fungal infections. And here we're going to talk about tinea corporis, onychomycosis, pityriasis versicolor, and a new and disturbing problem, emerging global dermatophyte resistance. We'll talk more about that in the next few minutes. Next. So let's just begin by defining what is a dermatophyte. So dermatophytes are molds that are closely related. There are several of these that we know of that have the special ability to infect the skin, hair, and nails. And when they infect the skin, hair, or nails, they can infect the body from head to toe. And we name the infection based on the body part that's infected with the preface tinea. So, for example, if the scalp is infected, the scalp hair follicles, we call it tinea capitis. If the face is infected, it's tinea faciei. So the name of the body part is put in Latin after the word tinea, and that's how we describe dermatophyte infections. Now, we used to think dermatophyte infections were fairly easy to treat since 1958, when griseofulvin became available. And then we had the birth of the azoles in the 80s with ketoconazole, and in the 90s with fluconazole and itraconazole. And then, of course, terbinafine came in the 90s. So we've all been complacent in thinking, well, these are easy to treat, not a big problem. We treat that with one of our favorite oral, topical, or both medications, and case closed. Not the case anymore. There's a growing global problem with dermatophyte resistance. Next. So let's just look at the planet. The countries identified in red show that they have been identified there trichophyte and rubrum isolates that are resistant to terbinafine, which is not good. And this was published a couple years ago. So since then, I would bet there are more countries that I've identified trichophyte and rubrum resistant dermatophytes, terbinafine resistant dermatophytes. We do see it in the US, they do have it in Canada, they have it in Europe, they have it in Asia, India, and so forth. So it's kind of pan-global problem. The second problem that's been identified recently, more recently, is a new organism named Trichophyton indotineae. Trichophyton indotineae emerged in India about in the last decade, where it's actually very, very common. And I recently spoke to a couple of dermatologists in India who told me that their clinics see several hundred patients a day with widespread resistant dermatophyte infections. So it's very common in that subcontinent. No surprise, it's spreading around the planet. It's been identified in Europe. It's been identified in Canada. And there was a report last week of 2 cases published in the MMWR by Kaplan et al., 2 cases of resistant trichophyton endotinea in New York City. Now, my colleagues from the UK, where they see this fairly, not often, but regularly, tell me that when they have patients, they almost all have some contact with India. However, what's unusual about the 2 cases in New York is there was no contact with India. One did go to Bangladesh. One had no travel history that we could identify. So we do have a global problem here. Next slide. Let's go back to routine tinea corporis. And to identify tinea corporis, you see patients like this with a red scaly patch. It may be small, it may be large. It has kind of an arcuate border. We call it annular. The edge is scaly. The center may be hypopigmented. It can be widespread. It can be small. The edge is scaly. And that's exactly where you do your KOH to identify the cause. You do a little scraping and you can find these septate hyphae that are generally colorless and straw-shaped under the microscope. And that confirms the diagnosis, and a fungal culture will confirm the etiology. So this is what I would say is routine tinea corporis. Next. However, tinea corporis may be difficult to diagnose, true or false. Sometimes it can be hard to distinguish tinea corporis from eczema, contact dermatitis, psoriasis, and even a drug eruption. The only way to correctly identify tinea corporis is through testing. KOH testing, potassium hydroxide testing, fungal culture, or PCR. And let's just look at these 4 patients who I presume have trichophyte endotinea. They came from India. And let's start at the bottom right. We have a man, you see his back, and you can see that well-demarcated patch on his upper back. And looking at that, you might think of a lot of things. Could it be a plaque of psoriasis? Could it be the Shaw sign of dermatomyositis? Could he have a photodrug eruption? You'd have to do a testing to find out. The person above him, the patient with that we're seeing the eye, is kind of interesting. You see hyperpigmentation on the eyelid, but around the medial aspect, there's a red scaly advancing border indicating that we do have a little dermatophyte fungus living here, a little problem. And she's probably had it for a long time because it's hyperpigmented, and it's probably been treated incorrectly with other things. So there is a problem here, and she has dermatophytosis. And then let's look at the hands. So we have scaly patches on the top of the hands. I might think if this patient came into my clinic, contact dermatitis, washing their hands a lot. Maybe they're atopic. Maybe they're plaques of psoriasis. No, this is now tinea corporis. And the bottom left, we have a well-demarcated patch on the leg. Could it be stasis? Could it be just xerosis, ichthyosis? No, this is dermatophytosis. And the only way to know what these patients have is through testing. You need to do KOH testing and fungal culture to identify the organism. Next. So how do you treat tinea corporis? Well, the 2 messages I want you to take home are, 1, do not rely on your eye. You need to diagnose. KOH, fungal culture is very important. Second point is you treat to terminate. You want to kill the fungus, not just make it better and have the patient leave, but you want to kill the fungus. So the objective is to terminate the fungus. Now, a simple patch of tinea corporis that's localized, topical treatments might be fine. And we've listed some of the over-the-counter products available in the US. When I instruct a patient to use these products, I tell them to apply it to the rash and to 1 inch around the rash twice daily for 2 weeks after the rash appears to be gone. And you're probably okay. Some patients, however, may need an oral medication. If you use terbinafine, you use 250 milligrams daily. Fluconazole, it's 200 milligrams daily, itraconazole 200 milligrams daily, and griseofulvin 500 to 1,000 or 1 gram a day if you are using that product. So it depends on the situation. Now, the patients we see from India are doing much better with itraconazole, and the duration of treatment is 2 to 3 months for most patients. So it's hard to just say you treat for X period of time because it depends on the condition. But the third point I'm going to make, besides that we don't rely on the eye, you treat to terminate, is terbinafine may not work. Terbinafine resistance is here. And how will you know it's here? Because patients have doctor shopped. They come to you with a rash and they said they saw the doctor down the street who gave them whatever. And then they saw someone else who gave them whatever. They're all antifungals. They're not getting better. They may have taken courses of terbinafine, but they still have the rash. So that would give you a clue that we have resistant dermatophytosis. Next slide. Here's the problem in India. So there's two things going on. We have dermatophyte resistance from our friendly trichophyton rubrum and probably trichophyton mentagrophytes also. But we also have the newly identified organism trichophyton tinea. How did this occur? It started in India. Well, one possible cause that's been published is in that area, you can get over-the-counter potent topical steroids and a plethora of antifungal creams. So people go to the store, buy what they want, treat indiscriminately without any testing, without any diagnostic confirmation. Now we're in a mess, and that's where we are now. So this study is going to bring attention to the matter. This was a well-designed clinical trial in India where 200 patients with tinea corporis were enrolled, 50 in 4 groups. One group fluconazole, one group got griseofulvin, one group terbinafine, and one group itraconazole. The patients were dosed correctly, as I reviewed already. The sad thing is, at 1 month of daily treatment, nobody had a cure rate over 8%. Nobody with 1 month of oral treatment. That's a little scary. At 2 months, it's even scarier. The only drug that hit over 50% was itraconazole. Itraconazole was the only drug. Terbinafine, what was considered the gold standard, has been with us. We're pushing, more than 25 years. The cure rate was less than 30%. So terbinafine may not be the answer in all patients. The azoles are more important at this point. So again, refractory tinea corporis started in India. It's spread to Europe. It's in North America, Asia. We have a newly identified species, trichophyton tinea. This may have been started because of failure to test, failure to obtain correct diagnostic information, and indiscriminate use of over-the-counter topical steroids and antifungals. Next. So now let's explore the problem in India that's coming on our door now. These are 3 patients. I think the patient on the right is the other side of the patient we saw earlier. And I want you to address your attention to the belly, where the belly button is. And you see that stria? Now, I'm looking at him, I will bet he used a potent topical steroid. And there's very potent topical steroids in India. And I assume he's been using that, and that's how he ended up with the stria. It doesn't look like what we see as routine tinea corporis, does it? It's very, very atypical. The middle patient with the hand, in quick glance, you might think hand eczema, maybe psoriasis, maybe an irritant contact dermatitis. And the patient on the left with the patch on the cheek, well, I might think tinea, but there's a lot of other things that could be. So the point is, resistant dermatophytosis is a huge problem in India, and it's here in the US. It may look very atypical. It's highly contagious. It spreads from person to person. No one is immune. You can get it whether you're healthy or not healthy, in all ages. So we have a big problem. And imagine how it affects your quality of life, especially if we have no treatment for it, or less effective treatment than we're used to. Next slide. Here are more cases. So the patient on the left reminds me of a patient I saw here in Alabama who, in retrospect, probably had trichophyton tinea because it was diagnosed originally as T. tegrophytes. And he had patches like this over his whole body, starting at his face, working to his toes. And he had doctor shopped all over the US, and he flew in to see me. He was pan-resistant, unfortunately, but he did have some susceptibility to fluconazole and itraconazole, and was eventually lost to follow-up. The patient on the right, you see ring on ring. That's very typical in this presentation of these treatment-resistant dermatophytoses. And the middle patient is very pathetic with that verrucous plaque on the scalp that you start even wondering, could this be some deep fungal infection? It's pretty scary looking. So these patients, including the routine trichophyte and rubrum resistant cases, have extensive disease, very contagious, disfiguring. Imagine how it impacts your quality of life, especially if they're not getting better. So resistance is an issue. And then are we asking, should we work these patients up for immunodeficiency? I've actually done that and haven't been very satisfied. I found nothing in any patient I've seen who's had T. rubrum resistance, or my one patient with T. tegrophytes resistance who may have had trichophyte endotinea. So that may not be a problem here. It's the fungus is very, very contagious. Next slide. So here's a patient I reported. He had 20 years of dermatophyte infection. It started on his toes, and he only had toenail fungus for a long time. And he came to me telling me, Doc, I've taken terbinafine. I've gone to several doctors. They keep giving me terbinafine and it doesn't work. I'm telling you that right now, it doesn't work. But by the time he saw me, he also had a rash on his hands, his body. He had a pretty bad infection. And the hands looked almost like an abscess. It was kind of thick and fluctuant, not good. So I did fungal susceptibility testing on him. And I think I started him on terbinafine anyway, because the other drugs were not that available, because he was on a potential drug that would interfere with the azoles, his apixaban. He was on that. And so his cardiologist didn't want him on an azole at the time. So when we officially got back that his trichophyte and rubrum was resistant to terbinafine, but it was sensitive to fluconazole, itraconazole, and griseofulvin, we elected to give him griseofulvin. Again, the cardiologist did not want an azole. That did not work so well. He got teeny better, but nothing to write home about. So finally, we switched around his drug. So he was on another anticoagulant. He was able to go on itraconazole. He took it successfully for 3 months. So the message is the patient shopped around, had widespread infection. That should alert you that you have resistant case. The second problem was widespread and horrible and spreading on him. History of not a failing terbinafine. He did respond to itraconazole, but itraconazole does have warts. It has drug interactions, and it can be, the absorption can be impaired with antacids. You have to take it ideally with food, but not with any antacids, because that would interfere with its absorption. So this patient was cured. He was a success with oral itraconazole. Next slide. So let's move on to onychomycosis, which is also known as tinea unguum if it's caused by a dermatophyte. So loosely, onychomycosis is a fungal infection of the nail, the fingernail or toenail, but you almost always see it in the toenail, not the fingernail. Fingernail onychomycosis is not common. It affects a large percent of our population, depending on the study. Roughly 10% of the US population has onychomycosis. And the older you are, the more likely you are to have toenail onychomycosis. Clinical signs are onycholysis, subungual debris. And the only way to make a diagnosis, the one and only way, is to do laboratory testing. You do your physical exam to rule out other things that the patient may have. You look for tinea pedis, but you want to do a fungal culture, a KOH. You can do histology, a PAS stain looking for septate hyphae, and a PCR. So you have options, but you want to make a diagnosis. Treatment is systemic antifungals. We'll talk about that in a few minutes, but systemic antifungals, there are topical antifungals available and devices, but systemic antifungals. And again, the theme will be Correct diagnosis, don't rely on the eye, and treat to terminate. Recurrence does occur. Next slide. So here's a first polling question. What is your diagnosis? And your choice is dermatophyte infection, nail psoriasis, mechanical trauma, lichen planus, or subungual squamous cell carcinoma. I think polling is still open. So put in your answer. We'll see how we do. Well, dermatophyte infection won as 83%. Nail psoriasis came in second, and mechanical trauma third. So what is the correct diagnosis? This is nail psoriasis, not onychomycosis. It's nail psoriasis. Nail psoriasis you can see on the fingernails and toenails. Fingernails, you see typical findings of pitting, onychomycosis with a red border, and oil spots. Toenails can be nonspecific. And to make it even more confusing, you can have both onychomycosis and nail psoriasis. Lichen planus, nails can look really horrible. Mechanical trauma, you may get a thick nail, but this is patient with nail psoriasis. Next slide. Another polling question. So what is your diagnosis? Dermatophyte infection, nail psoriasis, mechanical trauma, lichen planus, or squamous cell carcinoma. And polling is open. And the winner here is onychomycosis, 39%, mechanical trauma, 39%. So actually, I guess there's a tie. All right, so what's the correct diagnosis? What I want to point out is notice the yellow patch on the great toenail. That yellow patch, that's what we call a dermatophytoma. If you see this, you know it's onychomycosis. It's a yellow or orangish yellow patch. It's a dermatophyte abscess. And generally we see them after someone took, say, oral terbinafine. All their nails seem to improve. You didn't see them at the end, so you didn't see them clear. You just saw them clearing. But there was a colony or so of fungi that didn't get eradicated that formed an abscess under the nail. This is very hard to treat. So this is an example of onychomycosis. So I think the point is, do not rely on your eye. You need to diagnose this correctly. Next slide. Another polling question. What is your diagnosis? Here we have onychomycosis, nail psoriasis, mechanical trauma, subungual squamous cell carcinoma. And polling is open. Okay, so the winner is subungual squamous cell carcinoma is the first, and that is the correct answer. Mechanical trauma is the second, which I can see why that would be answered. So the point here is the patient, you don't know the history, but the patient had a painful toe with onychomycosis. Onychomycosis, when I don't know what's causing the onychomycosis, I cut back the onychomycosis. Notice the tumor in the nail bed. The nail was exquisitely painful. It's like the jump back sign. You touch the nail and the patient jump back. Cut back the onychomycosis, you see a tumor. This needs a biopsy. I also might consider x-ray this digit because what's right below the nail plate? You have bone. So you can get involvement of the bone with squamous cell and other carcinomas under the nail. So that may be something to consider doing. Next slide. All right, so one reason for onychomycosis failure is failure to test. You need to diagnose. The eye is not enough. Look for distal onychomycosis with subungual debris in the toenail. A thick nail plate is not enough. Observe tinea pedis. This patient has tinea pedis, a beautiful case of interdigital tinea pedis. You don't see the moccasin, but that's beautiful. You can see the fungal elements all over the place. I would assume by looking that this is dermatophytosis, and we did a culture to be thorough, and the patient did have it. But even though you think it is, still culture, do a PAS, do a KOH, you want to get a good history. The eye is not enough. Look for a past history of tinea pedis. Look for family members with tinea pedis. Have they gone to health spas, gyms? Have they gotten a pedicure? Do they go to a swimming pool? Those are things to ask. Next slide. To get the culture, you clean the nail, you cut it back, you scrape the bottom part away with a 15 blade or a little curette, and you can use that as your culture to send to your lab. You can use that also for a PAS. For your KOH. For the PAS, I just clip the nail, try to get some subungual debris to look for the septate hyphae in the nail plate and attached subungual debris. Fungal identification can be done with PCR analysis or fungal culture. Next. So again, we treat to terminate. We have 3 oral medications and some topicals. We're concentrating on the oral. The message today is terbinafine may not work. But it's not surprising because even when the drug came out and it was approved for 3 months of daily use, the complete cure rate was only 38 or 39%. It wasn't 100%. So now when I use terbinafine, and I still do use it, I use a minimum of 6 months, 3 months on, wait a month, because the drug's supposed to stay in the nail for up to 6 weeks, but I wait a month or a little less, and then another 3 months, during which time I'm evaluating the patient to be sure they're improving. If not improving, be sure your diagnosis is correct and consider resistance. Itraconazole, 200 milligrams a day, a minimum of 4 months, minimum. But I think 6 months to 9 months, you may need much longer if they have resistant cases. You can also pulse itraconazole at 400 milligrams a day, 1 week a month for consecutive months. So the first week of each month for the next several months. Watch for drug interactions. Fluconazole is not approved in the US for onychomycosis. I do use it. Here I use it once a week, 200 to 400 milligrams once a week. That's what I do until the nail is cured. So you may go on and on and on with this. Sometimes I do 400 milligrams twice a week. Next slide. So antifungal stewardship. The message is do not prescribe oral antifungal therapy for suspected nail fungus without confirmation. You can do a fungal culture, PCR. You can identify the organism, do your PAS stain. Looking for hyphae. If the lab just tells you they have yeast cells, forget it. That's junk. It may be unrelated. Treat with a full course. You treat to terminate. I treat now till the nail is normal or as normal as it's possible to be. Intermittent dosing, I'm referring to 3 months this year. The patient comes back 3 years later and says, Doc, my nail never cleared. You give them another 3 months of terbinafine. They come back a year. That could lead to resistance. Aggressive treatment may eliminate the uncertainty. And my next slide is moving on to a yeasty beastie, pityriasis versicolor, also known as tinea versicolor. It's caused by yeast found on our skin, a beautiful little yeast. It causes hypo or light colored patches, generally on the upper chest and back, the shoulders. It is quite beautiful in the lab. You see yeast cells and hyphae, also known as spaghetti and meatballs. You can treat it generally with topical antifungals like ketoconazole shampoo, ketoconazole cream, cycloperoxyl cream. Sometimes you need oral agents. Terbinafine never worked for this. Ketoconazole is gone now, oral, but you can use fluconazole or itraconazole, and I would use fluconazole, less drug interactions for 2 weeks daily for most patients, but it depends on the patient. So now, next slide, I'm turning this over to our next section, cutaneous manifestations of invasive fungal infection. So GR, take it on.
Yeah, thanks, Bonnie. That was great. Wonderful overview of the cutaneous mycoses. So we're going to move forward now to the more invasive fungal diseases. So talk about these four: mucormycosis, blastomycosis, fusarium, and coccidioidomycosis. Next slide. So mucormycosis has certainly been in the news a lot the last few years. We saw a big increase in cases in India associated with COVID-19. But traditionally, those groups at highest risk are people with poorly controlled diabetes, particularly those that come in with diabetic ketoacidosis. Other immunocompromised patients, such as leukemia or bone marrow transplant, solid organ transplant patients. And then there's also, this can be an implantation mycosis. So there were some cases in the New England Journal after a tornado where debris from the environment was stirred up and put at high speed, and then obviously impaled those patients, and the fungi from the soil caused implantation disease in those patients. So it can be a direct inoculum as well for mucormycosis. The types of infection we typically see are twofold. They're in our most highly immunocompromised patients, and they have pulmonary disease, or in our DKA or leukemics, and they have sinus disease sometimes as well. And so that's why it's really key. And we talk to our house staff about, when these patients come in, they really need to have a complete head to toe physical examination, even if they're really not complaining of anything. When their immune systems don't work with leukemia, they sometimes are going to just not notice that they have these manifestations of disease. And these are some pictures that are very similar to a DKA patient we just took care of, that on routine exam, we looked at their palate. They had a black eschar on their hard palate. They very quickly can spread to contiguous sites, cause this eschar, as you see here, over the nasolabial fold. And those can continue to progress and cause orbital involvement, central nervous system involvement. So CNS disease with mucormycosis is not uncommon. So what do you do for these when you suspect them? You need to call a surgeon that can help you with whatever the site of infection. So ear, nose, and throat, they're going to biopsy this for you. They'll do endoscopy of the nasal passages and sinuses. Anything that's numb, they'll biopsy. They presume that that's already had angioinvasion and necrosis. They take these patients to the OR multiple days in a row, and you really have to push for that, for aggressive debridement of these different areas. Ophthalmology is obviously involved if you think there's orbital involvement. And then really, you do need a biopsy and fungal cultures, and ask the surgeons not to ask them just to send a large chunk of tissue directly to microbiology and not to homogenize this. That will often kill mucormycosis and decrease your yield from cultures. And then obviously image the areas involved with an MRI scan for these, image their sinuses and orbit, brain, make sure that it's not spread, you have good control of disease, and then start antifungals with amphotericin B formulation. And then depending on who you talk to, they'll also add adjunctive echinocandin therapy. So these remain very morbid. Fortunately, we're not seeing quite as much of these as we used to due to prophylaxis in our highest risk patients, but COVID showed us there's continuing to be new emerging risk factors for the disease. Next slide. So blastomycosis. So blastomycosis has been in the news recently. Just last month, that was reported there was an outbreak in a paper mill in Wisconsin, the Escanaba paper mill outbreak, and one of those workers actually died. That since has been investigated by NIOSH and the CDC. I have not seen in the public domain, at least, what has caused and what is exactly responsible for that outbreak. These are usually, blastomycosis is usually environmentally acquired, right? It's acquired outside. So an outbreak for employees inside of a paper mill is pretty unusual. So that's the largest outbreak for blastomycosis that's been described. But those at risk are typically those in the South Central Midwest, United States, or in Canada. It does affect healthy patients. You don't need to be immunocompromised to have blastomycosis. And we talked a little bit about this outbreak, but how does it present? So these patients are going to have pulmonary disease or skin disease, and blastomycosis is a bit unique amongst the endemic fungal pathogens in that it does cause skin disease in a high number of the patients. So 20 to 40% of those with blastomycosis are going to have accompanying skin disease. Again, respiratory symptoms are pretty common with blastomyces, as well as most of the endemic fungi. But these skin lesions can look like a couple different things. You can see this top left photo here. These look like papules or warty-like growths. They also can ulcerate, as you see in the bottom right there. It can even mimic squamous cell carcinoma. They really need to be biopsied to ensure that you have the correct diagnosis. If you're thinking about fungal disease, you can do a touch prep of that. If you don't have the materials at hand to do a skin biopsy with a touch prep, send that to your pathology lab. They can read that for you, tell you that there's blastomyces on that touch prep. But the other testing you can do is antigen testing in the urine. You're going to want to image their chest to see what the burden of disease is. And then if you can get a skin biopsy and culture in what is very commonly asked on boards is these pictures of broad-based budding yeast, as you can see in the bottom left. So that's sort of very characteristic of blastomyces and cinches the diagnosis. You don't need to wait on cultures. Next slide. And then valley fever, coccidioidomycosis. So we see a lot of that here in California. Again, this is immunocompetent, immunocompromised people both. So really it's only in the Western Hemisphere within California, Arizona, now has spread to some other areas, Washington State, Utah, and then pockets throughout Latin America and South America. And those with most severe disease are those of oceanic descent. So our Filipino and Pacific Islander patients, African Americans also get very bad disease, as well as our immunosuppressed patients. But really anybody can acquire severe coccidioides. The good news is that most cases of cocci are asymptomatic. About 60% of people who have seen cocci, breathe it in, are asymptomatic or have subclinical symptoms where they don't come to clinical attention. The 40% that do come to clinical attention, the vast majority of those have a pulmonary complaint, either a subacute illness, cough, so-called valley fever, so pneumonia and joint pains. And a number of those will have benign rashes. So they'll have erythema nodosum, which is a paniculitis. It's inflammation of the fat, typically over the shins. But a minority of those will also have erythema multiforme. And you can see here some of these erythematous lesions in this top left picture. And that's just an immunologic manifestation of disease. That is not dissemination to the skin. In contrast to that, though, on the right side, you can see a patient with disseminated coccidioides infection, and that's an ulcerated lesion. You can tell that's actively infectious. These often drain, they weep a bit onto their bandages. If they leave their bandages on for a number of days, those actually are infectious. The spheral endospore form can convert back to a mold at that lower temperature on the bandage and become infectious. So that is a manifestation of disseminated disease and definitely needs antifungal therapy. And then to confirm the diagnosis, most patients with coccidioidomycosis are diagnosed by serology, just of blood, but you can also biopsy that. They have very characteristic lesions. You can see at the bottom, these spherules full of hundreds of endospores, and those are much larger than your white blood cells, which is one of the reasons it's so difficult to fight off this particular fungal pathogen. So next slide. And then now we'll move on to fusariosis caused by Fusarium species. This is a disease, in contrast to the other two, that patients are almost always profoundly immunosuppressed. They've been neutropenic for a long time or received a number of agents that have really knocked down their immune system. And the typical presentation for the patients we see in the hospital is these sort of erythematous lesions over their foot. It almost always starts as a nail infection in the feet. So when you examine your leukemic patients or those who are highly immunosuppressed, take their shoes and socks off, give them a very thorough exam. And then unfortunately with Fusarium, it can spread very quickly in these immunocompromised patients. Fusarium is one of the few fungal pathogens in humans that will cause positive blood cultures in a mold infection. And that's thought to be due to adventitious sporulation, where it can undergo sexual reproduction in tissue, and that leads to positive blood cultures. So when you think somebody has Fusarium, you can often recover that from blood cultures, but that's going to probably take a couple days. So a biopsy of the suspicious lesions with histopathology is going to be very characteristic. And it's a hyaline mold, so you can see here it's going to have septated branching hyphae. Histopathologically, it's going to look a lot like Aspergillus, so you need to have a high index of suspicion. And the problem with Fusarium is really it's highly drug resistant. So all the major species, particularly Solani, are going to have resistance and at best sort of elevated MICs to the majority of the antifungals that we use. So this is really an infection requires a high index of suspicion, need to be aggressively trying to do diagnostic testing. And then if you think that there's infection of the nail bed, that is a patient to remove the nail in those patients, really to debulk the source of infection for those with invasive fusariosis. Next slide. Okay, so we're going to move on to a little bit more of the exotic diseases. We don't see a whole lot of these, maybe just a couple cases a year. for the first and third there on the list. But the implantation mycoses, these are really fungi that get under your skin, so to speak. So chromoblastomycosis, sporotrichosis, and mycetoma. Next slide. So chromoblastomycosis, this is really an infection caused by a number of different species of fungi. So Fonseca, Cladophylophora, Exophiala, Phylophora, who's who of sort of unpronounceable fungi, but really seen primarily in tropical and subtropical regions. They are implantation mycoses, so there really needs to be preceding trauma from plants, thorns, other debris. And it has recently been added under the World Health Organization neglected tropical disease list of pathogens. So on initial presentation, it may start as just a small papule or a wart at the site of implantation. If you catch them very, very early, surgical removal of that site is all that's needed to be done, but that's very uncommon that happens. Unfortunately, they're often sort of overlooked by patients. They don't have a lot of symptoms during that time, and they can progress to the surrounding tissue. They can metastasize to distant sites. Uncommonly, they can cause significant lymphatic damage at their region of infection and cause lymphatic stasis. And with continual drainage, they can be confused with cutaneous squamous cell carcinoma. So to diagnose these, again, high index of suspicion, but really need a skin biopsy and KOH preparation and culture with histology. And they have very characteristic forms called sclerotic bodies or medlar bodies. Some people call them copper pennies on histopathology. So that is commonly asked on boards. So maybe something to kind of look into if you're not familiar with this. That tends to be the main question they ask about chromoblastomycosis on board exams, since it's so testable. But these, again, require a high index of suspicion, need to be biopsied, require long treatment courses with a pretty fair failure rate as well. Next slide. And then mycetoma. And mycetoma, most of these are of the foot. It really affects people of all ages, but are more common in men. They're typically in Africa, Latin America, and Asia, and equatorial regions. They require repeated breakdown of the skin. Again, an implantation mycosis caused by Madarella mycetoma, mycetomatous, although other species, Cedosporium, can be involved with mycetoma, but Madarella is the most common. Presents as these sort of painless and firm masses under the skin that contain these grains. And I think those of us in infectious disease aren't used to this, but you can actually take the grains and send those off for histopathology. And by the size of that and the color, they can often tell you what organism is responsible while you're awaiting culture results. Typically, this is of the foot, can be anywhere. It can certainly involve the underlying soft tissues and bone, be very disfiguring. Does require surgical intervention in a lot of these patients, has a high failure rate with antifungal therapy. But to diagnose these, again, this grain examination technique, microscopy and imaging, PCR, molecular sequencing are sometimes required to identify the organism to the species level. But there's also some mimickers. Actinomyces can cause a sort of skin disease that looks very similar to this, eumycetoma. But all of these really require long-term antifungals, and again, a very high failure rate associated with this disease. And next slide. And then sporotrichosis. So this really continues to emerge globally. So the majority of these reports were initially from Brazil, where Sporothrix has transitioned from a saprophytic pathogen existing on plant material to more of a zoonotic disease. And that's with Sporothrix brasiliensis that has been best described. And as it became more of a zoonotic disease and carried in high frequency on cats' claws, it then was able to be passed over to humans and cause really these huge outbreaks of infection throughout Brazil. Well, we're a little concerned that we're starting to see the same thing in the United States with Sporothrix schincki. We are seeing more cases. There are some reports of cat-associated Sporothrix schincki in the United States. So I think that's certainly something that the CDC is interested in and currently investigating. So again, it's the rose gardener's disease by sort of the textbook teaching, and you can see after a sort of an inoculation, you see as what we call the sporotrichoid march up the arm through lymphatic channels. You can see on the right the way these cats get it. They also can have a sporotrichoid distribution or direct inoculation in the nose here for this poor cat. So we typically will biopsy these skin lesions. They're not always culture positive. You can see some characteristic forms on histopathology. It's rare that they disseminate. Those are typically in patients who are highly immunocompromised. There were some reports in the New England Journal of sporothrix meningitis in the past. We really don't see that much anymore. But again, we take a history to see if they have any pets, biopsy suspicious lesions. Itraconazole really is the drug of choice for these patients. We often don't need to identify the organism to the species level, but they do require long courses of treatment, and they can affect the underlying tendons with tenosynovitis or even bone disease if they've had infection for a long time. So those are really all key aspects to consider during the care of these patients. Next slide. So to wrap up, and Boni did just a wonderful job talking about these different cutaneous mycoses, but think before you treat. Don't rely on the eye test, particularly for these cutaneous diseases and onychomycosis both. Resistant fungal infections are definitely going to be seen throughout the United States. I just got a call yesterday. Our VA here in Sacramento has a case of trichophyton endotinea. And think fungus as a potential etiology for unusual skin conditions, particularly in immunocompromised, and have a very low threshold to biopsy those and really get them started on therapy. So we will open it up for questions, I think, now. And thanks so much for your attention and time.
George, I really enjoyed your presentation. I would like to just make some comments and questions to you. Yesterday, as it turned out, one of my former residents who lives in the Colorado, I think near Denver, sent me a photo of what he biopsied. It was a well-demarcated red plaque that showed chromoblastomycosis. He thought he excised the whole thing, but he wasn't sure and said, "What do I do now?" I have in the past treated with itraconazole in healthy people when I'm not sure for 1 month. 200 milligrams a day. What do you do in that case?
Yeah, if they've got a plaque-like lesion or anything, I tend to treat them for quite a while longer, even after I think the disease has been eradicated. I completely agree. Excision in that circumstance looks great, but they don't have to miss very much for it to come right back. So I do treat them at least a month, usually for 3 months after it's gone. Yep.
I told him 1 to 2 months, depending on the situation, but 3 months might be better. And the second comment on chromoblastomycosis, I've seen it on the bottom of the foot. So it was implanted there. Someone thought it was a wart, and it was a warty growth. I mean, it looks like, verrucous, warty little growth. And we only found the diagnosis through excision, shaving it off and seeing those copper pennies in the under the microscope. So that was, just a little lesson learned, because if you have something that looks like a wart on your foot that isn't going away, it may need a biopsy. It may not be a regular wart.
Yeah, absolutely. It seems like those who really suffer the most morbidity from these diseases or they've kind of neglected it or had it blamed on something else. And that is an unusual sight. I assume they were barefoot when they acquired the disease.
Yeah, barefoot.
But yeah, I mean, I've pulled all of our cases here. We have about 4 cases a year. Dermatology sees almost all of them. Infectious disease had seen very few unless there was a complication or refractory nature of the disease. So these cases are definitely out there, but they're just in low numbers in the US.
And you use itraconazole 200 milligrams a day.
We do.
Yeah. I mean, we had a patient that had a dermatiasis, was a black fungus, and he was on organ transplant, and he had a lot of problems with it, and he should have been treated aggressively before he came to us. So I think that's a lesson learned. Another comment on fusarium is fusarium, as you mentioned, can be in the nail. And it actually is one of the few fungi that can cause white superficial onychomycosis, which just has these white patches on the toenail. And when you just get white patches, you scrape it off with a 15 blade and maybe put an over-the-counter antifungal on it or prescription, and case closed, you're probably cured. Fusarium won't respond anyway to terbinafine, so there's no point in giving oral. But with time, it can cause a totally dystrophic nail. And but I have seen digital cellulitis in patients who are in my bone marrow transplant unit who end up with disseminated fusarium, and it's not good. Mm-hmm. It's really bad. So that's another reason you need to be on the alert. If you see fusarium and you have a patient with white superficial onychomycosis, I treat, because fusarium is really common. And at least in Alabama, we see a lot of fusarium in the toenail, very common here. And you probably have it also out in California.
Yeah, disseminated fusariosis, we see about 2 to 3 cases a year. I mean, it's not, but they're devastating. Almost all of the patients die unless we catch
Yeah.
it very, very early. It's really a disease that we desperately need new drugs. There's several in various stages of preclinical development. Alorifim works for some of the isolates of Fusarium. Fosmanogepix works for a lot of the Fusarium isolates. So I think help is on the way, but not quite available yet.
Okay, and there was a question that came up during your talk asking, do you routinely do MIC testing on organisms? And when I do it for dermatophytes, I think it was from reference to dermatophytes. And I said, no, I don't. Insurance may not pay for it. Now, I hope we can get them to pay for it. And I hope more labs do it. But you often just have to assume that it's resistant because they're not responding, as long as you're correct on your diagnosis. But I do send out to a lab for MIC testing, and terbinafine resistance, they read it as greater than 0.5 micrograms per ml is resistant. Is there a standard test for this that you do?
So when we are concerned about resistant, we send those to the fungus testing lab in San Antonio, Texas. And
Yeah.
I think I saw Nathan Wiederhold even on the call today, who's the director of that lab.
Right.
That's just a fantastic reference lab. I think they do really fantastic work with that. And then the endotinea isolates, I think they have a pretty characteristic mutation in ERG1 that gives them resistance to terbinafine. And that may actually be why you see the azole MICs crawl up a little bit too. Just if there's a defect in squalene epoxidase, that further down with ERG11, the azoles are going to have reduced efficacy in some cases as well. I don't think that's been proven quite as well with endotinea compared to some of the other trichophyton species. But I think if you're thinking about resistance, don't send it for just terbinafine. Send for what you're planning to use as well. And I do see that mistake made on patients that are sent to us.
Right. He replaced Mike Rinaldi, and I learned a lot of mycology from Mike Rinaldi and his group.
Yeah.
Mike was a great guy.
We all miss Mike.
Yeah, he was a great guy. I think we had a case of trichophyton endotinea, and it was told originally to be T. mentagrophytes. And I guess the organism doesn't conidiate, and it's hard to identify it. So it would be probably the T. introdigitale variant, not T. mentagrophytes variant. But so be on alert if the lab tells you it's trichophyton mentagrophytes, it may not be. It may be this endotinea, which is here, unfortunately. And you'll probably recognize it because the patient's going to be really, really pathetic. Just remember those pictures. I don't know if there's another question. I can't open it. Can someone read any other question?
Okay, so we had this question about with respect to lab stewardship. Are you sending cultures, histopath, and PCR testing at the same time, or are you proceeding in a stepwise fashion?
Well, for dermatophytes, I do a KOH to confirm the diagnosis. If I can't do a KOH, I'll have a PAS. So one or the other tells you the same thing. It's the presence of fungi, your KOH or your PAS. Again, the PAS of a nail has to have hyphae, not spores or yeast cells. So that confirms the presence. These days, I like to know what is occupying the nail or the skin. So I do fungal cultures, but PCR is quite easy to do too. And the price of that has come down. So we have other options. Do I do them all in everybody? No. Insurance issues are generally the limiting factor, but I don't like to treat unless I've truly established the diagnosis. And often KOH, PAS is all I do, one or the other.
There's another question. We have been consulted a few times for mold growth, such as rhizopus, on nail cultures obtained for evaluation of onychomycosis. Would you consider targeted treatment for these in any specific scenarios?
Rhizopus is an interesting fungus. They're bread molds. They're lid lifters in the lab. They grow fast in the petri dish. They're not going to cause onychomycosis. So if I grew rhizopus, I would say, well, that's just what was growing around in the lab that day. It's not significant. I mean, if the PAS was positive, then they have something in the nail. You just don't know what it is. So in that case, I assume it's a dermatophyte. I might treat. If they aren't responding, then you want to really just try to get that culture. But rhizopus would be a contaminant. Are there any other questions, Lisa?
No, I don't see any more.
Well, this has been a lot of fun to reviewing all the different presentations on the skin of fungal infections. And we began with the dermatophytes. We talked about the yeast candida, Malassezia. And then we moved on to what gets under your skin and what gets in your skin, the implantation mycoses and some of the dimorphic organisms. I think we've done quite a bit in this hour, and I thank you so much for attending, and thank George for joining me, and I learned a lot from your talk.